Imagine stepping into a pediatric ward in a busy, under-resourced hospital.
Right.
The air is thick with heat, there's that smell of antiseptic, and it's just chaotic.
Yeah, totally chaotic.
Nurses are rushing between cots, IV lines are strung up literally everywhere, and there's a mother sitting next to a 2-year-old child who is just horrifyingly still.
It's a really chilling scene to walk into.
It is. The child's eyes are sunken deep into their skull, their skin looks kind of doughy, and when they try to cry, there are absolutely no tears.
Which is a massive red flag.
Exactly.
Yeah.
Now, if you are, say, a medical student or a frontline clinician or just someone who wants to understand the brutal realities of global health, your first thought might be, oh, this is malaria, or maybe pneumonia, or some rare metabolic crisis.
Sure, those are the usual suspects we jump to.
But the actual culprit putting that child on the brink of circulatory collapse is something that, well, in the developed world, we usually treat with a day off school and some ginger ale.
Yeah, simple stomach bug.
Yeah, right. So today, we are undertaking a massive start-to-finish masterclass on pediatric diarrheal diseases.
And, that contrast you just painted there, the difference between a minor inconvenience and a fatal crisis, that's exactly why we have to completely dismantle how we think about this condition.
Because it's not just an inconvenience in this context.
Not at all. We are dealing with an apex predator of the developing world. To defeat it, we have to strip away the casual terminology and approach it with absolute clinical precision.
Welcome to today's deep dive. This conversation is tailored specifically for you, whether you are, prepping for a medical board exam, refining your triage skills, or just insanely curious about the physiological tipping points of the human body.
Absolutely.
Our mission today is exhaustive. We are going to move from the rigid clinical definitions and the staggering global burden of the disease all the way down into the microscopic pathophysiological mechanisms that basically cause a gut to fail.
It's a fascinating, if terrifying, journey.
It really is. From there, we'll walk through a meticulous head-to-toe clinical assessment of dehydration. And finally, we'll arrive at the precise, life-saving mathematical formulations for oral rehydration therapies.
Which is the ultimate goal, right? Saving the patient.
Exactly. So let's jump right in. Let's start with the absolute baseline. In medicine, we usually like precision, right? Blood pressure numbers, lab values.
Right, objective data.
But the clinical definition of diarrhea isn't a lab value. It's actually a strict visual.
Yeah, it's highly observational.
It's defined as the passage of 3 or more loose stools in a day. And the clinical definition of a loose stool, it is one that takes the shape of its container.
I've always thought that is the ultimate example of pragmatic frontline medicine.
How so?
Well, if you ask a terrified parent if their child's stool is watery, their definition of watery might differ entirely from yours.
Yeah, for sure. It's totally subjective.
Right. But if you ask, if you put this stool in a cup, would it take the shape of the cup? You just instantly remove all that subjectivity.
Wow. Yeah, it becomes a binary question.
Exactly. It's a yes or no that instantly dictates whether you are initiating a life-saving protocol.
I love that. Takes the shape of its container. It immediately standardizes the history-taking process across, different languages and cultures.
It really does.
But once we establish that baseline, we have to sort of categorize the threat. Because not all diarrhea is created equal.
Not even close.
Let's walk through the specific subtypes, because they kind of dictate the clinical war we're fighting.
Sure, let's unpack those.
First up is acute diarrhea, which is also known as gastroenteritis. This one is sudden onset, lasts a few days, and is self-limiting.
Yeah, and this is the most common presentation by far.
So what's happening in the body here?
The child's body basically identifies an invading pathogen, hits the panic button, and attempts to physically flush the organism right out of the gastrointestinal tract.
Just a total system purge.
Exactly.
Yeah.
Assuming the child's fluid volume is maintained during this flushing process, the immune system eventually clears the bug, the gut lining repairs itself, and the crisis usually resolves within about a week.
Okay, but the danger arises when the flushing doesn't stop.
Right, that's when we enter a whole different territory.
And that brings us to persistent or chronic diarrhea. This starts as an acute episode, but it drags on for 14 days or more.
14 days is a long time for a child's body to endure that.
It is. And the math here is terrifying. 13 to 20% of all pediatric acute diarrhea cases evolve into this persistent form.
That's a huge proportion,
I mean, almost 1 in 5 children who get a stomach bug in these high-risk regions end up in this prolonged state.
which represents a catastrophic escalation in risk.
Duh.
You have to remember, the human gastrointestinal tract is designed to absorb nutrients.
Right.
When it is inflamed and purging fluids for over 2 weeks, it just completely stops absorbing proteins, fats, and micronutrients.
So the child is basically starving, even if they're eating.
Exactly. The child enters a state of rapid starvation. Their nutritional status plummets, which blunts their immune system, making it even harder to fight off the original infection.
So it's just a devastating downward spiral.
It truly is.
Then we have a category that sounds like an absolute diagnostic nightmare. Protracted diarrhea.
Oh, this one is incredibly tough for clinicians.
The sources define this as continuing for 4 weeks with no known cause and, crucially, no response to specific or non-specific treatments.
Just imagine being the clinician in that scenario. You have run all the stool cultures. You have tried antibiotics, antiparasitics, dietary changes.
And nothing works.
Nothing. And yet, for a month, the child continues to lose fluid.
What do you do at that point?
In these cases, you are often looking past simple infections to really complex autoimmune enteropathies, or severe congenital malabsorption syndromes, or even hidden systemic diseases.
It just requires incredibly complex investigative medicine to solve.
Absolutely. You're playing medical detective on hard mode.
Okay, next subtype is dysentery. This is a highly specific one defined by one chilling visual diarrhea with visible blood in the stool.
Yeah, blood in the stool changes everything.
We know from the sources this is frequently caused by Shigella species, but also Campylobacter, enteroinvasive E. coli, and Salmonella. When you see blood, what is that telling you about the microscopic battlefield?
It completely changes the management algorithm. It tells you that the pathogen is not merely irritating the surface of the gut, it is actively destroying tissue.
Like burrowing in.
Exactly. It is burrowing into the mucosal wall, causing microulcerations and actually breaking open blood vessels.
Wow.
So you're no longer just managing fluid loss, you are managing a deeply invasive, tissue-destroying infection that carries a really high risk of sepsis.
That is terrifying. And finally, just to balance out the terror a bit, we have toddler's diarrhea.
Ah, yes. The one bit of good news.
These are mild to moderate episodes in toddlers of variable duration with no established causes. But the vital distinction here is that there are no constitutional symptoms.
Right. The child has no fever, no lethargy, and no nutritional impairment.
So what's going on there?
It's often just a diagnosis of reassurance. The child is running around the clinic, playing, gaining weight normally, but simply having loose stools.
Because of what, exactly?
Sometimes it's due to excessive juice consumption or just a naturally rapid transit time in the gut.
But we always have to contrast that benign presentation with the staggering global burden of the infectious types we just talked about.
We really do. We can't let toddlers' diarrhea lull us into a false sense of security.
So let's get into the scale of that burden. Globally, we are looking at 2 billion cases per year in children under 5.
2 billion. It's hard to even wrap your head around that number.
It really is. And close to 1 billion of those cases are concentrated in Africa, Asia, and Latin America.
Right, in the developing world.
And the mortality rate is a tragedy of massive proportions. 2 million under 5 deaths globally every single year.
It's just devastating.
And more than 80% of those deaths occur in those same 3 regions. It is the third leading cause of under 5 mortality globally. It accounts for about 17% of all child deaths.
To put that into perspective, that is roughly equivalent to wiping out the entire population of a major metropolitan city, composed entirely of toddlers and infants every single year.
Oh my God. When you put it like that,
It's horrifying.
and when we drill down into specific regional data, like the Nigerian context outlined in the sources, the numbers become even more acute.
Nigeria is a really critical case study here.
In Nigeria, diarrheal disease is the single most common cause of mortality for under 5 children upon admission to the hospital.
The most common cause, period.
It causes 151,700 under 5 deaths annually just in Nigeria. That is the second highest burden in the entire world, trailing only India.
And beyond the sheer loss of life, consider the burden on the healthcare infrastructure itself.
The sources mention that an astounding 13% of all child life spent in a hospital in Nigeria is due to diarrheal disease.
Just think about the resources required for that. The hospital beds, The nursing hours, the thousands upon thousands of liters of intravenous fluids.
It just physically overwhelms the capacity of these pediatric wards.
It completely drains the system.
So we have to ask the fundamental question. Why is the gap between the perception in the global north and the reality in the global south so wide?
It's a great question.
Like, why does a rotavirus infection in London mean a missed week of daycare, while the exact same virus in Lagos can be a death sentence?
It really comes down to a concept we call the vicious cycle with malnutrition.
Unpack out that first.
Well, in a well-resourced environment, a child usually enters an acute diarrheal episode well-nourished. They have fat stores, they have muscle mass, and most importantly, a robust immune system.
Right. They have a buffer.
Exactly. In developing nations, a child might already be living on the absolute razor's edge of their daily nutritional requirements.
They basically have zero physiological reserve.
Zero. So when the diarrhea hits, it severely limits nutrient absorption and causes massive fluid loss. The child instantly drops into acute malnutrition.
And that makes the infection worse.
Yes, because that malnutrition depresses their cellular immunity, meaning their body can't fight off the bug.
Oh, I see.
And even worse, the gastrointestinal tract requires a massive amount of protein and energy to constantly rebuild its cellular lining. Without those nutrients, the gut literally cannot heal the damage caused by the pathogen.
So the damaged gut causes more diarrhea, which causes more nutrient loss, which prevents the gut from healing.
It's a self-feeding biological fire.
Wow. Which is a perfect pivot into understanding the environment this fire thrives in and the specific pathogens providing the sparks. Let's look at the epidemiological web and the usual suspects.
Right. We generally categorize these pathogenic invaders into three main families. We have viruses, bacteria, and protozoa.
And the roster from the sources is pretty extensive.
It's a long list.
Under viruses, we are tracking rotavirus, Norwalk, and Norwalk-like agents, corona-like virus, adenovirus, and HIV.
That's the viral lineup.
Then for bacteria, we have Shigella, Escherichia coli, which is an absolute chameleon we'll dissect later, Salmonella, Campylobacter jejuni, Yersinia enterocolitica, Staphylococcus aureus, Vibrio cholerae, and Clostridium species.
All major players.
Finally, the protozoa include Entamoeba species, Giardia lamblia, and Cryptosporidium.
That is a formidable array of microscopic threats. But, they don't strike randomly.
Right.
They exploit specific vulnerabilities, which epidemiologists divide into host factors, meaning vulnerabilities within the child, and environmental factors.
Let's examine those host factors first. Age is a massive predictor, specifically the window from 6 months to 2 or 3 years old.
Yes, that is the danger zone.
Other factors include depressed immunity, undernutrition, which we just explored, and poor personal hygiene. But let's zero in on that specific age window. Why does the risk suddenly skyrocket at exactly 6 months old?
Because that age perfectly overlaps with a really critical transition in a child's development.
Which is?
Well, before 6 months, an infant is ideally exclusively breastfed. Breast milk is practically sterile, and it is packed with maternal immunoglobulins, specifically IgA.
And what do those do?
They literally coat the infant's gut and act as a chemical shield against pathogens. Plus, a 4-month-old isn't very mobile. They stay in a pretty controlled environment.
But at 6 months, the shield drops and the exposure spikes.
Precisely. At 6 months, weaning begins. The infant is introduced to supplementary foods and external water sources, which, depending on the environment, might be contaminated.
So they're losing the protection just as they're getting exposed.
Exactly. Simultaneously, the protective maternal antibodies begin to wane, and the child's own immune system is still incredibly naive.
And what else happens around 6 to 9 months?
They start crawling.
Right.
They become highly mobile, and their primary method of exploring the world is, putting every single object they find directly into their mouth.
It's a perfect storm. Age and malnutrition lower the body's natural drawbridge, and then the environmental factors supply the invading army.
That's a great way to look at it.
The sources list these as poor environmental hygiene, a lack of potable water, overarching poverty, inadequate health provisions, and seasonality.
Without potable water, mothers are often forced to mix weaning foods or infant formula with contaminated water.
Which is just heartbreaking.
It is. You are essentially delivering a concentrated dose of bacterial pathogens directly into a gut that has just lost its maternal immune protection.
And different pathogens target different demographics within this storm, right?
Yes, they have different preferences, so to speak.
Cholera, for instance, is actually uncommon in very young infants. It typically strikes children 2 years and older and adults.
Yeah.
Shigellosis is most common in young children under 5. Rotavirus specifically targets the youngest infants and children aged 1 to 2.
Right, right in that weaning window.
E. coli is indiscriminate, it can strike at any age, and amoebiasis tends to be more common in adults.
We also really have to understand how these pathogens travel. The vast majority utilize the classic fecal-oral route.
Right.
Microscopic amounts of infected feces contaminate a water supply, or maybe a caregiver's hands, or a food source, and are then ingested by the host.
But there are some terrifying exceptions here.
There always are.
Shigella is often transmitted person to person because it requires an incredibly small infectious dose.
Yes, very highly contagious.
Nosocomial, or hospital-acquired transmission, is a huge risk on crowded wards. But the transmission route that truly underscores how formidable these pathogens are is rotavirus.
Oh, rotavirus is a beast.
The sources say it can be airborne. How does a gastrointestinal virus travel through the air?
It all comes down to viral load and environmental persistence.
Okay, walk me through that.
When a child with a severe rotavirus infection experiences explosive diarrhea or projectile vomiting, literally millions of microscopic viral particles are aerosolized.
So they just float up into the room.
Yeah, they form an invisible mist that can hang in the air of a poorly ventilated room, or they settle on surfaces, cribs, toys, doorknobs.
So a child doesn't even need to ingest contaminated water?
No, not at all. They just need to be playing in the same daycare room, inhale the aerosolized droplets, or touch a contaminated plastic toy and then put their fingers in their mouth.
That is wild.
Because rotavirus can survive for hours on dry surfaces, it sweeps through pediatric wards and daycares with astonishing speed.
Okay, so we have identified the enemies. We know how they breach the host's defenses through contaminated water, airborne droplets, and weaning vulnerabilities.
Right.
But what exactly do they do once they reach the gastrointestinal tract?
That is where the real sabotage happens.
The sources break it down into 4 distinct mechanisms of microscopic sabotage.
To truly understand the sabotage, though, we first have to understand the normal, healthy operation of the gut.
Let's set the baseline.
Let's look at basic GI physiology. The gut is constantly managing a massive flux of fluid and electrolytes.
The fluid enters the GI tract from 2 main sources, right? The liquids we actively ingest and massive amounts of endogenous GI secretions, saliva, gastric acid, bile, and pancreatic juices.
Exactly. We are talking about liters of fluid being dumped into the stomach and intestines every single day just to facilitate digestion.
And normally the body is a master of recycling all that fluid.
A total master. This net fluid and electrolyte exchange occurs along the intestinal line.
Those are the millions of tiny finger-like projections that line the gut to increase its surface area, right?
You got it. Now, net absorption of fluid happens at the very tips of these villi. Conversely, net secretion of fluid happens down in the crypts, which are the deep valleys between the villi.
Absorption at the tips, secretion in the crypts.
Yes. And in a healthy, steady state, absorption completely dominates.
So the body takes back what it put in.
Exactly. The absorptive cells at the tips pull almost all of that fluid back into the bloodstream before it reaches the end of the colon.
So diarrhea occurs when this delicate balance is violently flipped.
Exactly. There is either an unnatural increase in secretion from the crypts, a catastrophic decrease in absorption at the villus tips, or, in the worst cases, both simultaneously.
Okay, let's use a factory assembly line analogy to visualize these 4 pathophysiologic mechanisms.
I like that.
Mechanism number 1 is the stimulation of intestinal secretions, or secretory diarrhea.
Right.
The primary culprits here are toxin-producing pathogens, specifically Vibrio cholerae and enterotoxigenic E. coli, or ETEC.
In our factory analogy, these pathogens don't physically destroy the machines.
So what do they do?
Instead, they get ingested, survive the stomach acid, and set up camp in the intestinal lumen. From there, they elaborate powerful enterotoxins.
So they essentially drop chemical bombs onto the factory floor.
That's exactly it. These enterotoxins bind to very specific receptors on the surface of the mucosal cells.
And then?
This binding triggers an internal cellular alarm system. It induces an enzyme called adenyl cyclase to produce a massive unnatural excess of a messenger molecule called cyclic AMP, or CANP.
Let's unpack the biochemistry there. What does this rogue messenger, this CAMP, actually do to the factory?
It completely reprograms the machinery. First, the excess CAMP goes to the absorptive cells of the villus tips and actively inhibits the influx of sodium chloride and water.
So it turns off the absorption conveyor belts.
Exactly, but it doesn't stop there. It then travels down into the crypts and actively induces the massive secretion of chloride ions.
And what happens when chloride is secreted?
Well, it drags sodium and water out with it. It essentially turns the secretion pumps onto maximum overdrive.
The result is the gut forcefully pumping massive volumes of water and electrolytes out of the bloodstream and into the intestinal lumen.
Yes, liters and liters of it.
And here is a clinical detail from the sources that cannot be overstated. This secretory process persists even if the patient is fasting.
And this completely destroys the old dangerous myth of starving a stomach bug.
Which is such common advice.
I know, but it's completely wrong. Withholding food and water in a case of secretory diarrhea does absolutely nothing to stop the fluid loss.
Because the toxin is still there.
Right. The enterotoxin has chemically padlocked the secretion pumps in the on position. The gut will continue to hemorrhage liters of fluid even if the stomach is completely empty.
Wow.
If you starve the child, you are merely accelerating their descent into hypovolemic shock and malnutrition.
That is a phenomenal takeaway. Okay, let's move to mechanism number 2, mucosal adherence.
This is a totally different strategy.
The pathogens utilizing this strategy include enteroaggregative E. coli, EAEC, enteropathogenic E. coli EPEC, Giardia lamblia, and Cryptosporidium.
So if secretory diarrhea is reprogramming the factory, adherence diarrhea is essentially paving over the conveyor belts.
How does that work?
Well, these organisms do not produce massive secretory toxins, nor do they deeply invade the tissue.
Okay.
Instead, they attach themselves intimately to the mucosal surface and cause what we call effacement.
Effacement meaning a physical flattening.
Exactly. The healthy microvilli usually stand tall and separate, almost like the bristles of a fine toothbrush.
Which creates a massive surface area for absorbing water.
Right. But when these pathogens adhere, they destroy the cellular scaffolding that holds those bristles up. The microvilli melt and flatten out.
So the surface area is gone.
Because the surface area is drastically reduced, the absorptive capacity of the gut just plummets. The fluid from the stomach simply washes right past the flattened cells and out of the body.
Mechanism number 3 is mucosal invasion, and this is where things get really violent.
Oh, this one is nasty.
The invaders include Shigella, enteroinvasive E. coli, EIEC, Campylobacter, and Salmonella.
Right.
These organisms don't just sit on the surface. They actively burrow into and destroy the mucosal epithelial cells.
Going back to the analogy, this is the equivalent of the invading army physically blowing up the factory walls.
Brutal.
They invade the cells of the colon and the terminal ileum, replicate inside them, and actually cause the cells to rupture and die.
The destruction causes the shedding of dead cells, forming microulcers all across the gut lining, and the body responds with massive inflammation, producing an overlying exudate. Because the intestinal walls are physically ulcerated and bleeding, the stool produced usually contains visible blood, thick mucus, and leukocytes.
Which are the white blood cells rushing to fight the infection.
Right.
This severe mucosal damage not only halts absorption, but it triggers intense spasming intestinal motility as the gut desperately tries to expel the invaders.
And there is a fascinating caveat regarding rotavirus here in the sources.
Yes.
The clinical notes state that rotavirus also replicates within the epithelium and causes mucosal damage, but it usually doesn't result in bloody stool.
Which is an important distinction.
Why does it act differently than the invasive bacteria?
Rotavirus specifically targets the mature absorptive enterocytes at the very tips of the villi.
Okay.
It enters them, multiplies, and kills them, which blunts the villi and leaves the secretory crypt cells functioning unopposed.
But no blood.
Right, because it typically doesn't burrow deep enough into the foundational tissue to aggressively rupture blood vessels the way Shigella does.
Oh, I see.
It's a shallower, patchier form of invasion. That's why we rarely see frank dysentery with rotavirus.
That makes total sense. Finally, we arrive at mechanism number 4, increased osmolality or osmotic diarrhea.
This one is more about basic physics than toxins or invasions.
This occurs following the ingestion of osmotically active substances. This includes lactose in a child with a lactase enzyme deficiency, or non-absorbable solutes like lactulose or laxative abuse.
To visualize this, imagine flooding our factory floor with thousands of dry sponges.
Okay, I'm picturing it.
Osmotically active substances are molecules that the gut is completely incapable of absorbing into the bloodstream. Because they remain trapped inside the intestinal lumen, they exert osmotic pressure.
So they act as chemical magnets for water.
Exactly. The laws of osmosis dictate that water will always move to dilute a higher concentration of solutes.
Right.
So these unabsorbed molecules literally suck fluid out of the surrounding intestinal tissue and into the gut lumen, creating large volumes of watery stool.
And there are two crucial diagnostic clues for osmotic diarrhea.
What are they?
First, if you test the stool, there are no leukocytes, no white blood cells, because there is no bacterial invasion or severe inflammation.
Spot on.
Second, unlike secretory diarrhea, this type abates with fasting.
Because if you stop feeding the child the lactose they can't digest, you remove the chemical magnets from the gut.
And the osmotic draw ceases and the diarrhea stops. It is entirely dependent on ingestion.
Perfectly explained.
Before we move on, we have to mention that while infectious agents are the primary culprits globally, a clinician must keep their differential diagnosis wide open.
Absolutely. You can't just assume it's an infection.
The sources list a slew of non-infectious causes. You could be dealing with anatomic defects like malrotation of the bowel or Hirschsprung disease,
Anyway,
malabsorption issues like cystic fibrosis or celiac disease, food poisoning from heavy metals or wild mushrooms, endocrine issues like thyrotoxicosis, or even neoplasms like neuroblastomas.
it really highlights the danger of tunnel vision.
For sure.
If you have a protracted case that simply isn't responding to antimicrobial therapy or fluid management, you have to step back. You have to consider if you are dealing with a structural, genetic, or oncological mechanism rather than a simple infection.
So we have dissected the four mechanisms of microscopic sabotage. But these pathogens don't come with name tags.
Unfortunately not.
They present as a sick child. The microscopic pathophysiology dictates exactly what the child's macroscopic symptoms will be.
Right.
Let's transition into the clinical profiles, what I like to call the pathogen lineup.
Profiling the clinical presentation allows a physician to make highly educated guesses about the underlying mechanism before any lab results ever return.
Let's start with the viral heavyweight, rotavirus.
Okay, rotavirus is sneaky.
Very sneaky. It has an insidious onset, frequently starting with prodromal symptoms that actually mimic an upper respiratory tract infection.
That URTI prodrome is a classic clinical trap.
A child might have a cough, a moderate fever, and vomiting for a day or two before the diarrhea ever begins.
Right. A doctor might examine the child, hear the cough, see the fever, diagnose a mild viral respiratory bug, and just send them home.
Only for the explosive gastrointestinal symptoms to start hours later.
Exactly, leading to mild or moderate dehydration.
And when the diarrhea does hit, the stools are watery or semi-liquid, greenish or yellowish, and classically described in the literature as looking like yogurt mixed in water.
That is a very specific, unforgettable description.
Next in lineup is the violent invader, shigellosis.
Shigella.
This causes the frequent passage of scanty, small amounts of stool that are mostly mixed with blood and mucus.
Right, the dysentery presentation.
We are looking at a child with a moderate to high-grade fever, severe abdominal cramps, and a deeply distressing symptom called tenesmus.
Tenesmus is agonizing.
What exactly is it?
It is the constant, painful feeling of needing to empty the bowels, accompanied by involuntary straining, even when the bowels are completely empty.
Why does that happen?
It occurs because Shigella is actively ulcerating and inflaming the rectum. The nerve endings in the inflamed tissue are misfiring, falsely telling the brain that the rectum is full.
That sounds awful, and the surprising clinical feature of shigellosis. The sources say there is usually no dehydration.
Which perfectly aligns with mechanism 3.
Right.
Shigella is invading and destroying the colon. It is not turning on the massive fluid-dumping KMP mechanisms up in the small intestine.
So the child isn't losing liters of water.
No, they are passing small amounts of inflammatory exudate. The immediate threat to life isn't hypovolemic shock, but rather systemic infection, severe tissue damage, and potential neurological complications from the fever and the toxins.
Next, we have to profile Escherichia coli, which is less of a single pathogen and more of a deeply versatile bacterial family.
It really is. E. coli has so many tools in its toolbox.
The general clinical features are watery stools, common vomiting, moderate to severe dehydration, moderate fever, and mild abdominal pain.
Right, but the breakdown of the 6 distinct types of E. coli is vital here.
Let's walk through the arsenal. First is enterotoxigenic E. coli, or ETEC.
This is your classic cause of traveler's diarrhea. It utilizes mechanism 1, producing toxins that cause massive secretory fluid loss.
Okay, second is enteroinvasive E. coli, or EIEC.
This pathogen essentially mimics Shigella. It invades the mucosa, causes microulcers, and results in bloody dysentery.
Third is enteropathogenic E. coli, or EPEC.
This one uses mechanism 2. adhering to the infant's gut lining and flattening the microvilli. It often causes severe outbreaks in neonatal wards.
The fourth one is particularly notorious: enterohemorrhagic E. coli, or EHEC. This includes the infamous O157 H7 strain.
Oh, this one is very dangerous. It produces Shiga-like toxins that cause severe bloody diarrhea and can lead to hemolytic uremic syndrome.
What's that?
It's a terrifying condition that destroys red blood cells and causes acute kidney failure.
Wow. Okay, then we have two highly specialized adherent types. The fifth is enteroaggregative E. coli, or EAG.
These bacteria have fimbriae that allow them to stack on top of each other, basically forming a thick biofilm that resembles a stacked brick wall on the gut lining.
Like actual bricks.
Yeah, microscopically.
Yeah.
This biofilm chronically irritates the mucosa, making it a leading cause of persistent, long-lasting diarrhea.
And the sixth is diffuse adherent E. coli, or DAEC.
Unlike the stacked bricks, DAEC binds randomly and diffusely all over the host cell.
And what does that do?
It triggers a cellular signal that causes the host's microvilli to abnormally elongate and wrap around the bacteria like tentacles. It completely disrupts the cell's ability to absorb anything.
It's astounding how one species of bacteria has evolved 6 entirely different mechanisms to destroy the human gut.
Evolution is a relentless arms race.
Now let's look at the silent assassin, cholera.
The presentation for cholera is truly unforgettable.
The patient passes classic rice-watery stool. It literally looks like the cloudy water left over after washing rice. There is profound, rapid dehydration, projectile vomiting, severe muscle cramps, hypovolemic shock, and scanty or absent urine.
It's extremely aggressive.
And the defining clues: absolutely no fever and no abdominal pain.
Cholera is the purest manifestation of mechanism 1.
The secretory mechanism.
Right. The toxin locks the crypts open, and the patient essentially bleeds water from their bowel.
But why no fever?
Because there is no tissue invasion, so there's no inflammatory immune response.
Yeah.
No inflammation means no fever.
And no pain either.
Exactly. There's no ulceration, which means no pain. The excruciating muscle cramps are purely mechanical. They are the result of the body rapidly losing massive amounts of sodium and potassium.
Epidemiologists are obsessive about classifying Vibrio cholerae. We are required to note the specific biotypes, classical and L-Tor, and the serotypes, Inaba and Ogawa.
They track those very closely.
Why does tracking this microscopic taxonomy matter so much?
Because it dictates pandemic response.
How so?
The L-Tor biotype, for example, is responsible for the ongoing 7th global cholera pandemic. It is hardier, survives longer in the environment, and causes a higher proportion of asymptomatic carriers than the classical biotype.
Oh, I see.
By typing the specific strain, public health officials can predict how fast an outbreak will spread through a refugee camp or a city and tailor their containment strategies accordingly.
Finally, we round out the lineup with amoebiasis.
Ah, the protozoa.
This infection presents with offensive, bulky stools containing mucus and sometimes blood. The patient will have lower abdominal cramps, a mild grade fever, and generally no dehydration.
Again, this points to a localized, invasive inflammatory process primarily in the large intestine.
So that's why it's bulky.
Yes, the bulk and foul odor are classic signs of emetic tissue destruction rather than the massive small intestine volume dumping we see with cholera.
So we have played the clinical detective. We know the bugs and their calling cards.
We do.
But here is the brutal reality of the emergency room. You do not have time to wait for a stool culture to confirm your suspicions.
Not at all.
While you are guessing the pathogen, the child is actively dying from fluid loss. This brings us to the absolute core of clinical survival: the physical assessment of dehydration.
This is where theory ends and life-saving practice begins. We have to meticulously walk through the diagnostic flow.
Right. It starts with history taking.
Yes, you have to extract a massive amount of precise data from a usually panicked caregiver in a matter of minutes.
You need to establish the child's exact age, the onset and duration of the illness, and the severity.
And by severity, we mean the exact frequency of stools, the estimated volume, and the presence of visible blood, pus, or specific odors.
You also have to ask about food and water hygiene, whether they've ingested osmotic substances or traditional remedies, their current feeding or breastfeeding status.
What fluids the parents have already tried to give, whether they've been in contact with sick individuals.
Their past medical history and associated symptoms like vomiting, fever, reduced urine output, or convulsions.
It's a massive checklist.
It is. And while you are rapidly processing that history, your brain needs to be scanning for high-risk factors for dehydration.
These are the red flags.
A child is immediately triaged to the highest risk category if they are under 12 months of age, if the mother has recently discontinued breastfeeding, if the child is passing more than 8 loose stools a day.
If they are vomiting more than twice a day, or if they have underlying severe malnutrition.
Any of those factors means their physiological reserve is already exhausted.
Exactly.
Then you move your hands to the patient for the physical exam flow. You assess their general appearance, their level of consciousness. You physically inspect the stool if a diaper is available.
You take anthropometrics, calculating the exact percentage of recent weight loss, if you have a baseline weight, and you conduct a systemic exam.
Which brings us to the clinical signs table.
This table is arguably the most important conceptual framework in pediatric emergency medicine.
It categorizes dehydration into degrees: none, mild, moderate, and severe. We are going to detail every single parameter because understanding why the body reacts this way is how you catch a child before they crash.
Let's visualize examining a single patient moving head to toe.
Parameter 1 is general appearance. In none or mild dehydration, the child is well and alert.
Right.
In moderate dehydration, they become restless and irritable.
Yep.
In severe dehydration, they become lethargic, drowsy, or unconscious. Why does a lack of water make a child increasingly irritable and then suddenly comatose?
It is a direct reflection of brain perfusion.
Okay, explain that.
As the total blood volume drops, the body senses the circulatory stress and dumps adrenaline into the system to keep the heart pumping hard.
And adrenaline causes the restlessness.
Exactly. That adrenaline surge causes the extreme irritability in the moderate stage. The child is physiologically panicking.
But then they go lethargic.
Because as the volume loss progresses to severe, the heart simply cannot pump enough blood against gravity to reach the brain. The brain becomes starved of oxygenated blood, the central nervous system depresses, and the child slips into lethargy and eventually an unconscious state.
Parameter 2, the eyes. Normal hydration means normal eyes. Moderate dehydration leads to sunken eyes. Severe dehydration results in grossly sunken eyes.
The human eye rests on a cushion of retroorbital fat pads.
Behind the eye?
Right. And those fat pads are highly reliant on interstitial water content. As the body desperately pulls water from every available tissue to keep the blood vessels full, those fat pads are drained and they shrink.
So the eyes actually sink back.
The globes of the eyes physically sink backward into the skull. It is a haunting, unmistakable visual cue of deep cellular dehydration.
Parameter 3, tears. Normal hydration, tears are present. Moderate, tears are reduced. Severe, tears are absent.
Examining a hysterically crying infant and realizing their cheeks are completely dry is a terrifying moment for a clinician.
I can imagine. Why does that happen?
It shows you that the body is actively triaging fluid. The autonomic nervous system recognizes that survival is threatened, so it violently shuts down all non-essential fluid expenditures.
Like tears.
Producing tears, making saliva, sweating, all of it is turned off to preserve whatever microscopic volume of water is left for the heart and the brain.
Parameter 4 looks at the anterior fontanelle, the soft spot on an infant's skull where the cranial bones have not yet fused.
This is a critical indicator for infants.
Normal hydration is normal tension. Moderate dehydration makes it depressed. Severe dehydration leaves it deeply sunken.
The tension of the fontanelle acts as a direct physical window into the intracranial pressure.
How does that connect to dehydration?
The brain is floating in cerebrospinal fluid, which is derived from blood plasma. When systemic fluid volume plummets, the pressure inside the skull drops and the soft membrane of the fontanelle physically caves inward.
That is wild. Parameter 5, mucous membrane. Normal is moist, moderate is dry, severe is very dry.
Simple, but effective to check.
Parameter 6 is thirst, and the progression here is uniquely tragic. Normal hydration, normal thirst. Moderate dehydration. The child is thirsty and drinks eagerly.
Right.
Severe dehydration. The child drinks poorly or is completely unable to drink. How does a child who is dying of thirst become physically unable to drink?
Because they have crossed the threshold from distress into decompensated shock.
Meaning?
At the moderate stage, the brain's osmoreceptors are screaming for water, driving the child to drink eagerly. But when they hit the severe stage, the lack of brain perfusion we discussed earlier takes over.
So their brain isn't working well enough to drink.
Exactly. They become so profoundly lethargic, weak, and uncoordinated that they literally lose the neurological reflex to swallow.
Oh, wow.
This is the exact moment where oral interventions fail, and if you cannot establish an intravenous line immediately, the child will die.
Parameter 7 is skin turgor, assessing the skin's elasticity, usually by pinching the skin on the child's abdomen.
A very classic test.
Normal. The skin returns normally and instantly. Moderate. It returns slowly, taking longer than 2 seconds. Severe. It returns very slowly, often forming a tent that stays pinched for well over 2 seconds.
Healthy skin is plumped up by interstitial fluid, the water hiding in the tissues outside the blood vessels.
So when you pinch it, it snaps back.
Right. In severe dehydration, that interstitial reservoir has been completely drained dry to support the circulatory system.
So there's nothing to push it back.
When you pinch the skin, there's no fluid to push it back into place. It just sits there, doughy, inelastic, and tented.
Parameter 8. Capillary refill. You press firmly on the child's fingernail bed until the tissue turns white, then release and count the seconds until the pink color returns.
This is a vital test.
Normal. Normal, instant return. Moderate. Delayed, taking between 2 and 4 seconds. Severe. Highly delayed, taking more than 4 seconds, and crucially, the limbs are cold to the touch.
Capillary refill is your direct gauge of peripheral perfusion. In a desperate bid to keep the core organs alive, the body clamps down completely on the peripheral blood vessels. It shunts all available blood away from the arms and legs and forces it into the chest and head.
So that's why they get cold.
Exactly. The extremities become ice cold, and the microscopic capillary beds in the fingers take agonizingly long to refill with blood after you compress them.
Finally, we monitor the vital signs, which tell the story of a failing cardiovascular system.
The heart is struggling at this point.
Pulse volume goes from normal to weak to feeble or entirely impalpable at the wrist.
Right.
Pulse rate goes from normal to increased to highly increased. The heart is beating incredibly fast, trying to circulate a dangerously small volume of blood.
It's working overtime.
Blood pressure attempts to remain normal, might decrease slightly in the moderate stage, but becomes heavily decreased or completely unrecordable in severe shock.
The pressure just tanks.
Respiration goes from normal to rapid and deep as the blood becomes acidic to decreased or absent as the respiratory muscles fail.
It's a terrifying progression.
Urine output goes from normal to decreased to completely absent as the kidneys shut down to stop any further fluid loss.
The body just closes every exit valve.
And the ultimate calculation of the total body water deficit. Less than 3% weight loss is categorized as none. 3 to 5% is mild. 6 to 9% is moderate. 10% or more is severe.
Hearing all of those parameters laid out back to back illustrates the overwhelming complexity of assessing a critically ill child.
Exactly. If I am the lone doctor in a chaotic rural clinic dealing with 3 crashing patients at once, I do not have the time to check 15 different clinical boxes and calculate exact weight loss percentages for every child.
No, you don't.
I need a shortcut. How do I quickly triage?
You rely on the best indicators.
What are those?
The clinical guidelines specifically star 5 parameters as the ultimate rapid-fire dashboard for assessing dehydration severity. They are general appearance, tears, mucous membrane, thirst, and capillary refill.
Okay, so is the child alert or lethargic? Are they producing tears? Is their mouth wet? Can they eagerly drink? And how fast do their fingers pink up?
Yes. If you can accurately assess those 5 specific signs in under 30 seconds, you can confidently categorize the child's dehydration and immediately initiate the appropriate life-saving protocol.
But the assessment doesn't end with calculating the missing volume.
Not at all.
Diagnosing how much water is missing is only half the battle. The composition of the fluid that is left behind in the body is just as vital.
This is a really crucial point.
This brings us to Section 6, the salt divide, or the types of dehydration.
This is where clinical management crosses over into complex cellular biology. We classify the type of dehydration based on the patient's serum sodium level.
Which dictates the plasma osmolality.
Exactly. There are 3 types we must understand: isonatremic, hypernatremic, and hyponatremic.
Let's take them one by one, using an analogy to visualize the cellular physics. First is isonatremic or isotonic dehydration.
This is the standard presentation, accounting for about 80% of cases.
The serum sodium remains in the normal range, between 130 and 150 milliequivalents per liter.
Right.
The sources note that the lost fluid is similar in sodium concentration to the blood. Because sodium and water losses are proportional, there is no osmotic gradient created across the cell walls.
Meaning the intracellular fluid volume, the fluid inside the cells themselves, remains unchanged.
So how do we visualize this?
Imagine the body's cells are sponges floating in a large bucket of salty water. The salty water represents the blood and the extracellular fluid.
Okay.
In isonatremic dehydration, the diarrhea acts like a cup, simply scooping perfectly mixed salty water out of the bucket.
So the bucket gets emptier?
The overall water level in the bucket drops dangerously low, but the saltiness of the water that remains is exactly the same.
Got it.
Because the salt concentration hasn't changed, osmosis doesn't occur. The cells do not shrink or swell. They just float in a much shallower bucket.
So the primary clinical problem is pure hypovolemia, a loss of volume in the blood vessels.
Precisely.
That makes perfect sense. Now let's explore the dangerous variations. Hypernatremic or hypertonic dehydration. This accounts for 5 to 10% of cases.
This one is very tricky.
Here, the serum sodium is elevated, measuring greater than 150. This happens because the lost fluid was hypotonic, meaning the diarrhea contained relatively more water than salt.
The child lost water but kept the salt.
Right. Because the blood is now hypersalty, water moves from the intracellular space into the extracellular space.
And the notes highlight a crucial, highly deceptive clinical detail here.
What's that?
The patient appears less dehydrated clinically for a given amount of total body water loss compared to isotonic dehydration.
Wait, really? Why?
Let's go back to our bucket of sponges. In this scenario, instead of scooping water out, imagine you are boiling the water in the bucket.
So the pure water evaporates, leaving all the salt behind.
Exactly. The water in the bucket becomes intensely, highly salty. Now, the laws of osmosis kick in. The highly concentrated salt water in the bucket actively sucks water out of the sponges to try and dilute itself.
So the cells are physically shrinking.
Yes, the intracellular fluid literally sacrifices itself, abandoning the cells to move into the bloodstream to keep the blood vessels full.
And this creates the clinical trap.
Exactly. Because the blood vessels are being artificially propped up by the water stolen from the cells, the child's blood pressure might stay stable longer.
Their skin turgor might still feel somewhat elastic.
Right. They don't look as severely dehydrated as they actually are, which might cause a clinician to underestimate their fluid deficit.
But meanwhile, their cells are drying out.
Yes, and their brain cells are shrinking and dehydrating, which can lead to seizures and permanent neurological damage.
It's a terrifying illusion of stability. And finally, we have the most immediately lethal variation. Hyponatremic or hypotonic dehydration.
This is a nightmare scenario.
This is another 5 to 10% of cases. The serum sodium is critically low, less than 130. The lost fluid contained more sodium than the blood.
Right.
Because the serum sodium drops, the blood becomes dangerously hypotonic. Intravascular water shifts rapidly into the extravascular space, moving from the extracellular fluid into the cells.
And the notes emphasize that this severely worsens the intravascular volume depletion.
What causes this?
Causes include specific renal salt wasting conditions, or tragically caregivers replacing gastrointestinal and skin losses with plain unsalted water.
This is a catastrophic double blow to the child's circulatory system, isn't it?
It really is. In our bucket analogy, the child has lost heavily salted fluid through diarrhea. To help, a well-meaning parent gives the child copious amounts of plain, pure water.
Which seems entirely logical to a parent trying to hydrate a sick child.
Exactly, but physiologically it is disastrous. Now, the bucket is low on overall volume, and the fluid that is left is heavily diluted. It has very little salt.
So it happens.
Suddenly, the water inside the sponges is saltier than the water in the bucket. Osmosis reverses violently. Water flees the already depleted blood vessels and rushes into the cells.
So the cells swell up like water balloons?
Yes, including the cells in the brain, leading to cerebral edema.
Oh.
But worse, for immediate survival, the blood vessels are rapidly emptied. The child lost volume to the outside world via the diarrhea, and now the remaining fluid in their veins is actively fleeing into their own tissues to chase the salt.
So the vascular system empties out almost instantly.
Exactly. This leads to a precipitous drop in blood pressure, irreversible hypovolemic shock, and rapid cardiovascular collapse. Hyponatremic dehydration is an absolute code red emergency.
That terrifying physiological cascade perfectly sets up our final and most important section.
Yes, how to fix it.
We have identified the pathogen's mechanisms. We have conducted our clinical assessment to find the exact severity of the volume loss. We understand the treacherous salt balances.
Right.
Now we arrive at the absolute core of clinical practice, fixing the math and saving the child's life. Let's look at the lifeline, prevention and treatment protocols.
Because the best treatment is the one that prevents the child from ever reaching the severe dehydration stage.
Let's start with prevention. The primary clinical advice for any diarrheal episode is unrestricted oral fluids and the absolute continuation of breastfeeding.
Breastfeeding is non-negotiable.
For high-risk cases, you advise unrestricted normal drinks plus exactly 10 milliliters per kilogram of oral rehydration solution, or ORS, after every single watery stool passed.
And the most critical public health intervention is teaching mothers how to properly prepare salt sugar solution, or SSS, at home.
That salt sugar solution is the direct antidote to the hyponatremic trap we just discussed, right?
Precisely. It ensures that caregivers in remote areas aren't just replacing massive fluid losses with plain water, which we know will crash the child's circulatory system.
But the brilliance of the salt sugar solution goes far beyond just replacing lost salt.
It really does. It relies on one of the most elegant evolutionary mechanisms in the human gut.
I read that the Lancet Medical Journal once called the discovery of oral rehydration therapy the most important medical advance of the 20th century.
They did. And it all comes down to a microscopic protein called the sodium glucose cotransporter, or SGLT1.
Let's explain how this works because it directly overcomes the secretory toxins we talked about in Mechanism 1.
Remember how cholera and ETEC use toxins to lock the intestinal fluid pumps into the secrete position?
Yeah, the padlock on the machinery.
Well, for decades, doctors believed that because the gut was actively flushing fluid out, you couldn't give fluids by mouth. You had to use IVs, which are incredibly difficult to deploy in rural outbreaks.
Right, that makes sense intuitively.
But scientists discovered that while the normal sodium absorption channels are blocked by the toxin, the SGLT1 cotransporter remains entirely unaffected.
It's like a hidden back door into the bloodstream.
Yes, but this specific transporter requires two keys to turn. It will only pull a sodium molecule across the cell wall if a glucose molecule binds to it at the exact same time.
So if you give a child just salt water, it passes right through.
Right, and if you give them just sugar water, it passes right through.
But if you mix salt and sugar,
If you mix them in the exact correct ratio, the glucose activates the transporter, pulling the sodium inside. And because of osmosis, wherever sodium goes, massive amounts of water follow.
so by giving a simple mixture of salt, sugar, and water, you actively hijack the gut's own biology to forcefully drag water back into the bloodstream.
Completely bypassing the effects of the cholera toxin.
That is breathtakingly elegant. But when prevention fails and clinical dehydration sets in, we must move to the correction of dehydration using specific oral rehydration therapy, or ORT.
The guidelines note that while intravenous roads exist, ORT is used for the vast majority of cases.
And the key is that this correction of the fluid deficit must be achieved over a very specific 4-hour window.
This is where the clinician becomes a mathematician. You are writing a highly specific fluid prescription based entirely on the child's exact weight.
Let's lay out the formulas from the sources.
Okay.
For mild dehydration, the strict requirement is 30 to 50 milliliters per kilogram of ORS delivered over 4 hours. For moderate dehydration, the volume increases to 60 to 90 milliliters per kilogram of ORS over 4 hours.
Got it.
And for the category titled some dehydration, the target is exactly 75 milliliters per kilogram of ORS over 4 hours.
And the protocol mandates that after that 4-hour window, you must perform a complete reassessment.
If signs of dehydration persist, you repeat the appropriate fluid calculation for another 4 hours.
The discipline required here is immense. You aren't just handing a mother a cup and saying, make sure he drinks.
Right, it's highly regulated.
You are measuring out exact milliliters, pacing it out over 240 minutes, and monitoring the intake to ensure the vascular system is being safely and steadily refilled.
Looking at these numbers, I have to ask a practical question.
Sure.
How does a clinician distinguish between utilizing the moderate range of 60 to 90 milliliters per kilogram and the very specific some dehydration category target of exactly 75 milliliters per kilogram?
It completely depends on the clinical setting and the specific global health guidelines being utilized.
Okay, unpack that.
The terms mild and moderate, with their sliding ranges of 30 to 50 and 60 to 90, allow for highly nuanced, hospital-based titration.
So that's for when you have more resources.
Right. A doctor in a fully staffed pediatric ward can use their clinical judgment to adjust the rate based on continuous minute-by-minute assessment of the child's heart rate and urine output.
But what about the some dehydration target?
The some dehydration classification is a cornerstone of the World Health Organization's Integrated Management of Childhood Illness, or IMCI, guidelines.
And what's the goal of that?
The IMCI was designed for use in under-resourced frontline environments. It intentionally simplifies the mild and moderate spectrum into a single highly actionable category.
Ah, I see. Mathematically, 75 milliliters per kilogram is exactly the midpoint between 60 and 90.
Exactly. By standardizing the protocol to a single number 75, it drastically speeds up intervention.
So a community health worker in a rural village doesn't have to debate the nuances of sliding scales.
Right. They just weigh the child, calculate 75 times the kilogram, start the fluid, and reassess in 4 hours.
It removes decision fatigue in high-stress, low-resource environments.
And it guarantees the child gets a safe, effective volume of fluid immediately.
It is protocolized survival.
That's a great way to put it.
We have covered an immense, almost overwhelming amount of ground today. Let's take a moment to briefly recap this journey.
It's been a lot.
We started with the beautifully pragmatic definition, the loose stool taking the shape of its container.
Right.
We scaled all the way up to the terrifying global burden, the millions of lives lost, and the devastating self-feeding cycle of malnutrition.
And then we zoomed microscopically into the 4 pathophysiological mechanisms.
The factory floors being chemically reprogrammed by enterotoxins, paved over by adhering organisms, violently blown up by invasive bacteria, or flooded by osmotic sponges.
We walked step by step through the clinical assessment, understanding exactly why a child's eyes sink, why their tears dry up, and why their fontanelle depresses.
We navigated the perilous shifting salt balances of the blood, and finally we landed on the exact mathematical formulas.
The precise milliliters per kilogram of life-saving oral rehydration solution required to pull a child back from the brink of hypovolemic shock.
And we must always remember that medical knowledge is only truly valuable when it is deeply understood and practically applied.
Absolutely. What we have meticulously detailed today isn't just academic theory for a textbook.
Right. It is the exact step-by-step roadmap that a clinician uses to reverse a fatal physiological cascade.
You know, before we wrap up, I do have a final thought to leave you with.
You usually do. You always leave us with something profound to think about, a new angle on the material that pushes the boundaries of how we view these diseases. What was your final thought for us today?
Well, I want you to reconsider mechanism 1, the secretory pathogens like cholera and enterotoxigenic E. coli.
The ones that drop the chemical bombs.
Right. We spent a lot of time discussing how they rely on highly specific mucosal receptors to hijack the enterocytes and turn on the fluid pumps via cyclic AMP. This raises a fascinating paradigm-shifting question. Could the future of treating pediatric secretory diarrhea bypass the use of antibiotics entirely?
Oh, wait, really? How so?
Currently, if a bacterial infection is severe enough, we use antibiotics, which is akin to carpet bombing the entire gut microbiome.
You kill the bad bacteria, but you wipe out the good bacteria, too.
Exactly, which brings its own host of complications.
Yeah.
But what if, instead, we could engineer highly targeted synthetic receptor blockers?
Like pharmaceuticals.
Pharmaceuticals, or even engineered probiotic strains, designed simply to cover up those specific biochemical locks on the surface of the gut cells.
So if the cholera enterotoxin is physically blocked from binding to the mucosal receptor,
It cannot trigger the fatal cyclic AMP cascade. The factory machinery never gets hacked.
wow, you just close the biochemical doors before the burglars even have a chance to pick the lock.
Exactly. The bacteria would still be in the gut, but they would be entirely disarmed.
That's incredible.
We could render massive historical killers like cholera into harmless passengers in the gastrointestinal tract, allowing the body to safely flush them out over a few days without a single drop of life-threatening fluid loss.
It would be a revolution in targeted, non-destructive medicine.
It really would.
That is a brilliant and hopeful concept to ponder. Thank you for walking us through this incredibly dense, crucial, and heavy material with such clarity.
It was my pleasure.
And to you, the listener, thank you for joining us on this deep dive. Whether you are heading into a grueling medical board exam, walking onto a chaotic pediatric ward for your next shift, or just navigating the world with a deeper appreciation for the resilience and fragility of the human body, take these life-saving details with you.
Yes, please do.
Because sometimes the difference between a simple inconvenience and a devastating global medical crisis really does come down to understanding the shape of a container and knowing exactly how to fill it back up.